Today I'm going to talk about the treatment of hypertension during the COVID-19 pandemic. This is just a short video just to summarize what we know and what you should do with your patients during this time. So I'm sure that all of you have heard about the news headlines about the potential interaction between ACE inhibitors and ARBs and the disease COVID-19. This paper I'd really like to highlight. It's quite recent, in the last week, in the New England Journal, and it goes over the evidence of what we know and what we should currently do. It's an excellent piece. But just to summarize the initial controversy, this diagram demonstrates the renin-angiotensin-aldosterone system and how it relates to SARS-CoV-2, which is the virus which causes COVID-19. So basically, angiotensin 1 is converted by ACE to angiotensin 2, and angiotensin 2 causes vasoconstriction and sodium retention in the kidney, which causes high blood pressure. But also, angiotensin and angiotensin 2 are related to local and systemic infections and sepsis, and they become activated, and they can cause acute lung injury, vasoconstriction, and cause problems with vascular permeability. So this system has been implicated in the COVID-19 as one of the potential mediators of lung injury. Now, the thing that links it with the SARS-CoV-2 virus is that the SARS-CoV-2 protein binds to ACE2. Now, ACE2 is an enzyme which converts angiotensin 2 into angiotensin 1,7. Angiotensin 1,7 antagonizes the effects of angiotensin 2, actually lowering blood pressure. So the initial report that came out, the hypothesis was that if we used ACE and ARBs, we would alter the amount or activity of ACE2, which could potentially either increase the effects of SARS-CoV-2 on the body, or increase kind of our ability to get lung injury. So this was just a hypothesis, and there is no clinical evidence that actually this happens. There is no evidence that ACE or ARBs increase the risk of lung injury. And in fact, the paper that I showed you suggests another hypothesis, that actually ACE and ARBs may be potentially beneficial in COVID-19 and actually protect lung injury. The bottom line is we don't actually know, and there are studies now currently underway looking at drugs like ARBs to see if they help in COVID-19. There have been a number of guideline statements about this to try and reassure both doctors and patients. And this one here from the ESC is very clear and explicit. The Council on Hypertension strongly recommend that physicians and patients should continue treatment with their usual antihypertensive therapy, because there is no clinical or scientific evidence to suggest that treatment with ACE or ARBs should be discontinued because of COVID-19. So it's very clear. We actually give this statement to our patients. This has been reiterated by multiple societies all over the world. So what we know is there is no evidence that RAS blockers improve or worsen outcomes for patients. What we also know is that if you stop an ACE or an ARB, it will abruptly increase a patient's cardiovascular risk. That is known from clinical trials, particularly if patients have heart failure or have MI, or even hypertension. That's abruptly stopping these drugs increases CV risk. What we also know is that patients with untreated hypertension have increased CV risk. So what should you do? So these three distinct patient groups, I'll just go over very quickly. In newly diagnosed hypertensive patients, we should stick with the guidelines. We should initiate single pill combination therapy to try and achieve control quickly. And I think we need to expect that we'll not see our patients so frequently at the moment. So we want to achieve control, and we want to get them down to target, and we want to reduce their cardiovascular risk. So we should use a single pill combination therapy. Very few people require monotherapy. Those that are very low risk, grade 1, yes, or very frail and old, yes, they can be started on monotherapy. So in summary, for newly diagnosed hypertensive patients, we should aim for quick control, minimize follow-up visits, and reduce CV risk. And in most cases, this will be a 2-drug fixed dose combination. In patients on an ACE or an ARB that are controlled, it's simple. Do not stop or change the ACE or ARB unless there is another compelling reason. And in patients on an ACE or an ARB that are uncontrolled, we should add another drug. It's pretty clear from the guidelines that your next step is not to increase the dose. You get best control or better control by adding another drug from another class rather than in increasing the dose of the pre-existing drugs. So if the patient's on 1 drug, add another drug. If the patient's on 2 drugs, add another drug. And it doesn't really matter. All classes get better if you add a different class of drug. So, and when you add this other drug, aim to use a fixed dose combination to improve compliance and blood pressure control. It's easier for the patient and it improves adherence. So in summary, there's no current evidence that RAS blockers improve or worsen outcomes for patients with COVID-19. This is a fluid area and we need to be aware that there may be new evidence on a daily basis, so we need to keep an eye on what's going on. Continue RAS blockers unless there are compelling reason to stop. Aim to control blood pressure as per guidelines to reduce cardiovascular risk. We also should aim to use fixed dose combination pills at the lowest dose and add a drug if not controlled, and try and reduce the pill burden. If you have any questions, I'm always free to be contacted at our clinic here. That's the WhatsApp number and the clinic number there. Thank you.